All right. Welcome back to Sunday. Hi. Hello. Yes, we know it's cold in here again this morning for those here in person. We're getting the heat turned back up. So we'll be, just bear with us. We'll get that back up to a balmy 84 in here shortly. So to start today, we have Dr. Lehrfeld here with us to talk to us about the state of EMS in Oregon.
Yeah, we'll talk about something.
Talk about some things. So I will let him take it away.
Oh, fancy. Okay,
Talk to them right there.
get the laser designator and everything. All right, how are you now? It's been a minute. I had to find this thing. It's been like 3 years since I've been out of my house, and Best Western hasn't gotten any better. They're more like okay Western. All right, so yeah, thanks for having me out here. Last day of the 2003 Eastern Oregon EMS Conference out here at Blue Mountain. And we're going to do the Oregon Health Authority weekend update, and I'm going to be your host. I'm Dave Lehrfeld. And we got a little bit to cover, so let's just jump right into it here. I set my timer because I always run over. Yes, sir. All right. Did everybody hear me? Okay, so I see you up there. Come on now. Nope, not working. We'll have to use the mouse. Nope, mouse not working either. All right. All right, the circus is here. 2003 legislative session. You can cue the music. Da, 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 da. No? There we go. All right. So get your buckets of popcorn out, kick your feet up, get ready for the show. I used to hate legislative session, but once I resigned myself to what a shit show democracy was, I actually kind of enjoy it now just to see what kind of crazy stuff people come up with. So let's start with the quote of the week. And this was Rep. Blumenauer's response to the Idaho legislation voting to annex Eastern Oregon. So congratulations or condolences. I'm not sure. I don't actually know where the line was, whether Pendleton made the cut, but apparently Idaho voted, and you're all part of Idaho now. I don't know. Before you get too excited, that's not actually a thing. You can't do that, but it was fun. But you know, I agree with Rep. Blumenauer. I'll take Sun Valley. I'm not sure who we should trade it for. Apologies to North Powder, but that's just what comes to mind right off the bat. It's a nice place, but Sun Valley is like really nice. Okay, so let's see what our nominees are for the most interesting bills that were dropped this session. So over 2,000 bills dropped on day one of the legislative session. We okay here? All right. And there's more bills coming out all day. Let me just do this disclaimer here. I'm going to just read it verbatim. Our lawyers gave it to me. The OHA does not support legislation nor oppose any legislation proposed by the legislature, but stands ready to enact the will of the people as determined by the legislature. Okay, now we've got that out of the way. So I have rated, I have perused all the legislation that has come out this legislative session and selected ones that I thought might be of interest to this body. And I've rated them 1 through 5. So 1 is, if this passes, it's definitely going to affect your life and what you do every day. 5 is, you should probably know about it because it's interesting in a good or bad way. And then, you know, there's everything in between. 2 is it's going to affect you a little bit. 3 is a moderate amount. 3 is going to affect you a little bit. 4, it's probably not going to affect you. And then 5 is it's not going to affect you at all. So that's what the numbers are. So in no certain order, let's start looking at what our elected representatives are doing for us this legislative session. So we have House Bill 2886 and the companion Senate Bill 408, and this is the scope of practice. So it directs the Oregon Health Authority to establish a process to receive, review healthcare profession scope of practice requests and impact statements. It defines what a scope of practice is. It defines an impact statement, directs the authority to combine temporary scope of practice request review committee. So we got to bring people together to look at these scope of practice reviews. It directs the committee to review the scope of practice and the impact statements and report to the legislature, an interim committee of the legislature. So that's a lot of words. What does that mean? So scope of practice, what you can do, what you can't do. Oregon has, I haven't read all 50 states' laws, but in all the states I've worked in, Oregon has the most expansive scope of practice in any state I've ever been in. And I've been in a few. If you want to, who has ever, Steve, where are you? Are you in here? There you are. So this is the president, ex-president, you're ex-president now. Chair, all right. President sounds cooler, but ex-chair of the scope of practice committee for EMS. And what is the procedure, sir, to get the scope of practice for EMS changed?
It's actually
Pretty
pretty easy to do.
easy.
You submit a request to the Oregon Medical Board, and they submit it to our committee. We discuss it and determine, hold a couple hearings on it. Get input from outside people, and if it passes, it becomes scope of practice.
Right.
Right now, we are in the process of changing scope of practice for the intermediates and adding benzodiazepines, which has gone through its first reading, goes through the second reading in May. And so I assume it'll go through in May, and then it'll get moved to full board, and the full medical board has to approve it at that point. So probably in this year, it'll be a scope of practice.
Yeah, I suspect that's right. So would you say it's a rigorous process or an unrigorous process?
It's not rigorous, it's just long.
Yeah, it takes a lot of time. And that's the way, Oregon Medical Board, Oregon Board of Nursing, EMS, respiratory therapists, whoever you are, you have a licensing board, chiropractic, naturopaths, you all have a licensing board, and your licensing board determines what your scope of practice is. And it's pretty similar to what Mr. Chair person described. You submit a piece of paper that says, I want to change the scope of practice. There's a committee that sits there, they discuss it, and then it's either thumbs up or thumbs down, and the scope of practice is changed. So this is going to completely change that. This, by the way, is supported by most professional organizations, mainly physician organizations out there, because one state licensing board cannot interfere with another state licensing board. So if the naturopaths, God bless you all out there, decide that they want to do brain surgery, and they can change their scope of practice to do that. And the brain surgeon doctors can't do anything about that. So that's kind of the purpose of this bill, is to bring more rigor between the licensing boards. And so anytime somebody, and this is, if you think it's, and like Steve said, something very simple, like during the pandemic, the medical board ordered an emergency regulation that said that the state medical director could change the scope of practice in an emergency. So we can do swabs, we can do vaccinations. You guys have probably all been doing that stuff for the past 2 years. That was like, boom, state medical director writes an order, it's law, right? Until the emergency is over. Versus the normal process where something like benzodiazepines for intermediates can take up to a year. Initial hearing, second hearing, up to the main board, but it's still not that rigorous. You don't have to present a lot of data. You don't have to do any test projects. You don't have to confer with other boards. You do have to do public comment, but so this is going to radically change the way your scope of practice and everybody's scope of practice has changed. The Oregon Health Authority, anytime there's a scope of practice change for anybody, nurses, doctors, anybody, it's gonna have to bring together a panel of experts, gonna have to do a scientific review, gonna have to do a financial impact statement, gonna have to go to the legislature, right, and present all the findings to them. And then it's unclear who gets the final call, whether it's gonna be this group or the legislature, but so this is big. This is priority one for us because it's gonna really change our ability to change our own scope of practice. And it's not necessarily a bad thing. Like I said, we don't have the government doesn't have a position on this, good or bad, but we as a community, it's going to bring more rigor to our change process, but it's also going to slow it down quite a bit. So scope of practice change bill, it's a big one. It's going to be priority one in its impact for us. As Steve mentioned, this is what they're doing right now. Like, so benzodiazepines for intermediates. Did the language on which benzodiazepines ever make it in there, or is it just going to be any benzo? Only for seizures, not for, because there was some debate whether it should be for agitation as well. Seizures only. Okay. That's, yeah, the Oregon Medical Board is changing your scope of practice as we speak to put benzos into the intermediate. All right, what's next? House Bill 2887, distribute naloxone. So first responders already administer naloxone to people suffering from opiate overdose. Right, first responders being police, fire, EMS. House Bill 2887 would allow police, fires, and other emergency responders to distribute naloxone kits to people for future use. So just a couple of technical terms: prescribing, administering, distributing. In the law, they have three different meanings, right? You guys administer. Technically, your medical director prescribed, you have standing orders, right? Your medical director prescribed it, you administer it. Only pharmacies can distribute, right? Only pharmacies can distribute, or pharmacists can distribute. So this law, which is likely going to pass, is going to give you the ability to distribute naloxone. And they've been doing this other states. This is an example in New York City. These little leave behind kits. We've been talking about this for years. The addiction specialists have been advocating for this for years. So you get a call, it's an opiate overdose, you revive the person, want to take them to the hospital, they'll thank you, they, refuse transport, the AMA, and you're like, hey, brother, before you go, just it's a little something for you, we'll take home, little swag gift, right?
Who's gonna pay for this for our distribution? That's what
You?
Is there funding for agencies to get kits?
What's that?
Is there funding in the bill for agencies to get kits?
Not in this bill. No, this bill just allows distribution.
Still gonna be an issue for us.
There's you know how this goes. There's going to be grant processes. There's the harm reduction warehouse. There's a lot of complexities around distributing naloxone and what monies can be used for it and what monies can't. But this bill is so Board of Pharmacy rules, right? All other things being equal, only pharmacists can distribute. That's why we have a pharmacy board. That's why we have pharmacists, right? You can't just buy a bunch of Narcan and set up a warehouse outside, set a vegetable stand outside your house and start selling Narcan, right? So prescribing, physicians, administering, you guys distributing, pharmacists. This bill makes a cutout for that, and it says everybody, pretty much everybody can distribute naloxone. You can leave naloxone behind. I should just mention that the feds are going to probably make naloxone over the counter within the next 12 months, so this might not matter, but you should know about it anyway, because exactly what you asked. It's like, okay, you can, and now how many people are going to come at you and go, you must, right? How many mental health organizations, addiction specialists, how many people with grants, how much from public health going to come at you and go, now that you can do this, you should be doing it. And the exact question comes up like, well, you're going to pay for it. Exactly. Okay. So that's House Bill 2887, distributing naloxone, which was a one for us, right? Because it's going to directly affect us. House Bill 2919, healthcare professionals, RNs, not all healthcare professionals, it says, but it's RNs, are protected from criminal prosecution. This is a 5. It's not going to directly affect us, but I want you guys to know about it. You know who this person is in this picture? Who is this?
I don't know her name directly. but-
Yeah, Rhonda Vaught.
I watched it.
Yeah, and why is she in front of you right now?
She gave her own medication.
Guy was going through an MRI. She was supposed to give him Versed to calm him down. She gave him Vecuronium and he stopped breathing. Which is a tragic medical mistake, but they convicted her of murder. Negligent homicide. Right, negligent homicide. Okay, up to 8 years. It turns out she got 3 years of supervised probation. As you might imagine, this pissed the nurses off really, really bad. Where was it? Vanderbilt University, I believe. Yeah, Vanderbilt. I'm seeing heads going up and down. Steve. What's that? Yeah, oh, okay. Benzos for seizures or agitation. Did they put in anything about combining it with opiates? Okay. All right. So this provides a registered nurses only, providing patient care in good faith is immune from criminal liability for an act of omission that is part of a provision of care unless the offense has been intentional or there's a knowingly culpable mental state, right? So they did it on purpose, basically. Like, it's medical malpractice, yeah, but you can't be criminally charged unless you did it on purpose. So why am I putting this in front of you, right? It's a 5 for us, right? It's not going to directly affect us. Anybody know who these people are? And by the way, if you're in one of my slides, it's never a good thing. It's just like, this guy's in front of you, he's the most awesome freaking medic in the world. Yeah. Yeah. So the guys on the right are firefighters from Aurora, Colorado, that in 2001, a grand jury handed down indictments in the case surrounding Elijah McClain, who died after an interaction with police and EMS. The indictment of the 2 paramedics. So as you know, indicting police officers for deaths in custody has become a thing for these past 3 years. But this was the first case that I know of where they indicted medics as well. 10 counts for crimes including manslaughter, criminally negligent homicide, assault with a deadly weapon, conspiracy. Does anybody know what the deadly weapon was that they assaulted Elijah McClain with, according to the DA? Ketamine. So the deadly weapon they assaulted him with was ketamine, according to the DA. All right. Yeah. Well, I mean, we're living in, this is why this is in front of you now, right? Nurses have the nursing union specifically have a piece of legislation that's going to make, if it passes, will make them immune from criminal liability. Our community has no such equivalent piece of legislation in front of our legislators, but you could literally like take out nurse and put in paramedic or EMT, and it would basically be the same bill, should anybody want to do that. And you know, the paramedics on the left, these were the ones on the right were firefighters. They might get out of it on sovereign immunity, who knows? The ones on the left, though, they're screwed, right? These are private medics that work for a private company. They threw a guy down on a stretcher face down, put the straps on him, got him to the hospital. He wasn't breathing. They have been charged with, I don't know how the DA got here, first-degree murder. First-degree murder, both of them. They have no sovereign immunity, right? They work for a private company. They potentially could spend the rest of their lives in jail. Could.
Yeah.
I mean, it's first-degree murder, right? That's intentional. It's not an accident. It's not negligent homicide. The DA charged them with first-degree murder. Okay. So that's why that nursing bill was in front of you, because it has come to us now. Their DAs are leveling charges against EMS workers for acts of omission, right? That you guys didn't do what you were supposed to do, and you're criminally negligent, not just malpractice. So the nurses are looking to protect themselves. I don't know what the EMS community so far hasn't done anything in our state to protect themselves. All right, what's next? House Bill 2825 allows Office of Emergency Management to grant licenses of one for us, right? So during the pandemic, we needed more of everything. And the boards were tasked by the governor, the nursing board, the medical board, our board, EMS, were tasked with, like, find everybody who retired or quit and bring them back and relicense them. And it was, yeah, right? That's what we said. It was like, okay, let's go through all our old records and call everybody up and then bring them back and just give them a license, like no testing, no CE, just bring everybody back. And nobody really figured out how to do it, right? Because the whole purpose of licensing is to assure, the safety to the public. You actually have competent providers out there. And so the order really went nowhere, mainly around nursing, right? Everybody got all up in the nursing board's business for not being able to do this. So somebody thought, well, let's just give it to OEM, and OEM can just issue licenses to everybody who's ever had a license in the state of Oregon as a healthcare provider. So the bill is really kind of that simple. It says it authorizes the Department of Emergency Management to issue temporary professional licenses during states of emergency to individuals formally licensed by certain professional licensing board. That's kind of language. It's unclear how they would do this, what sort of vetting they would do, how they would coordinate with the licensing boards, but that's, what this law does. So I think it's kind of priority one for us, since we seem to have a governor declared emergency almost yearly, whether it's a wildfire, a snowstorm, a pandemic, an eclipse. I mean, I've been doing this job for like 9 years, and I think there's like the first 3 years we didn't have a governor declared emergency, but like every year after that we have. So I think this could really affect what we do. Oh, Grandpa back on the ambulance again. Okay, House Bill 2833, opioid deaths. I'm calling this a 3, and let me explain myself. So this directs the Oregon Health Authority to develop and maintain electronic systems to collect information about the administration of naloxone, right? Or other specific drugs, and deaths resulting from opioid overdose. So, as many of you have been around for more than a couple of years, remember, we came to you, I came to you in 2016. I said, we have no statewide EMS data system. People are writing shit on paper like cat and tree, lights and sirens, rescued Amira, and that went into a filing cabinet. So we got a grant. We created a statewide EMS data system, which I assume everybody's using. What's that? Image trend, or whatever you want to use. It was kind of complex. We had to get everybody to agree to do it. We had to say, whatever you're using, we'll take that data and we'll provide you a free record. And you guys, thank you. You all supported it. We got it passed. So we have a statewide data system now, so we can actually say what we're doing. And one of the things we do with this data system is we partner with other programs, such we're public health. So, wash your hands, don't poop in your drinking water, that kind of stuff. But, overdose. So we have violence and injury prevention program, and we export our data to them, your data to them. And they, you can go on our website right now and you can look at these data dashboards that we put up. These are, oops. I have to stay back by the mic, but these are opioid overdoses per county, you can select how you want to. Deaths, right, hospitalizations, everything. We put all this data up there. So, this is a reason I call it the circus, right? Somebody comes with an idea. It's like, my son overdosed. The state should be tracking overdoses. And then a legislator writes a bill, says the state has to track overdoses. And then we're like, yeah, we've been doing that for years. So it's a level 3 because I don't know whether this is going to require us to do anything else. Because when I read the bill, it's like, yeah, we've been doing that for years. You should come visit our website. It's pretty good. There's all sorts of stuff out there.
So is this where OD Maps came from then?
Where OD Maps, I do not know OD Maps. We export this data de-identified to a lot of sources. We send it to HIDA and Department of Justice. We have it for public health. I don't know OD Maps, so.
Something that I just heard about from our EMS chief. Sounds like anytime we have the OD call, we're gonna start inputting information into another website, so that way they track the overdoses.
So I talked to your chief 2 days ago, and I didn't show him the website, but I told him, like, we're already doing this shit. So, you know, so have him call me. Because we're on it. What's that? I don't know. So if there's a, you know, so this is HIPAA protected information. So we do a little filtering, and, you know, if there's only like 2 overdoses per county and everybody knows everybody in Harney County, then, right. So we do some filtering here. You can only get so granular with this data. Now, if you're a public health official and you want the complete data set, you know, and the proper protections are in place to protect, you know, the individuals, you can get it. But this is our public facing dashboard. So this is crude, but we have the granular data, like down to, this is your data, right? So this is EMS naloxone. So we have every single chart and all the details of it. But we're not going to give that to the public or the news or the Department of Justice or anybody else. This is protected. This is HIPAA protected data, and we're only going to publish, you know, non-granular data to the general public. But to your chief's point, like, you don't have to fill out an extra database. That stuff is already there. We just have to set it up so if an appropriate public official needs the data and they can put protections in place to protect the individual, then you can get the data for public health purposes. And by the way, we do that. If you've never been to our website, we can do the same thing for, we have all sorts of performance measures like pain treatment for traumatic injury, Jamie. We have, you know, beta agonists for asthma. We have use of lights and sirens. We have all sorts of public dashboards from this data, right? De-identified data up there for what you guys are doing. In the future, we're going to produce individual reports for agencies. So how is every agency in the state, 140, stop, you know, and like a bar graph, like where you fall in there, right? For your individual agency. We need time to get there, but we're going to be doing it. Anyway, God, we're way behind. I'm talking too much. Oh, 29, 26, RNs training in hospitals. This is level 4 for us for a couple of reasons, right? You're going to see a lot of RN stuff in here because the nurses have been very politically active, right? And in good ways. And for some reason, the EMS community is not doing it. Probably they have a lot more money, they have more lobbyists, they have more time. So this is going to supply grants to the directs the Oregon Health Authority to establish a program to provide financial incentives for hospitals to offer clinical training opportunities to nursing students, right? So clinical training sites in all the hospitals. You open up your hospital for nursing students, you get cash, right? So we do this, we've been doing this forever for MDs and DOs, right? So if you have a residency program in your hospital, you get from the state's Medicaid fund, you get like $150,000 to $200,000 per year per resident that you have there for providing that training site. So it's going to be a similar thing for RNs, right? As all of you know, the healthcare system sort of collapsed during the pandemic, it hasn't recovered. And what we found out is it's not about beds, it's not about vents, it's about nurses, right? It's not about beds, it's about staff beds. So this is going to give them money. This is going to hopefully, if it passes, incentivize hospitals to provide clinical training opportunities for nurses. And as you know, if any of you are part of a community college or paramedic program, the hardest thing in a paramedic program is to get clinical training sites, right? You can use anything as a didactic classroom, like PowerPoint, a couple of mannequins, but clinical training sites are the #1 hardest thing to get. They come and they go constantly. But people like money. So if you give hospitals money to have clinical training sites, you're going to have more clinical training sites. So 4 for us. Very similar bill, House Bill 2928, extends healthcare provider incentives programs to healthcare providers who are students enrolled in health professional training programs, leading to the licensure as a licensed practical nurse or registered nurse, right? So this is a program out of the Office of Rural Health, the provider incentive program. It's basically, again, for MDs and DOs, and it provides loan repayment, loan forgiveness, insurance subsidies. Not a problem for nurses because they don't have to carry malpractice insurance, but a big problem for doctors, and then tax credits. So this bill basically says, hey, you got to do the same thing for nurses, right? Again, trying to increase the nursing workforce. It's a 4, I believe, for us because, it's going to increase the nursing pipeline, which is going to help us because of wall times and things like this, but also because it's a model for us. Why aren't we doing this? Who's a recent graduate from a paramedic program? How long, after you have your MT, how long does it take you to get a paramedic?
So I was kind of backwards, but I'll say 3 years once I finally started the process with paramedic.
3 years?
3 reacts.
Yeah. You were already in EMT.
As an EMT.
Okay. And you?
I was an EMT when I decided to go back to school. It took me 3 years.
Okay. So 3 years, the shortest program that I'm aware of, and any educator can correct me on this, is 1 year. Like it takes at least 1 year to make a paramedic. And why is that? It's because
With the program that I went to, as far as like school, there is one of my classmates was done in 8 months.
8 months. That's really good. Most of our programs, you go 2 8-hour classes per week. All right. And why is that? Because you have a job, right? You're EMTs and you're working full time and you're doing your paramedic work on the side, right? No matter who's paying for it. And so that's how our colleges are structured, right? It's structured to take paramedic classes around your full-time job, right? So when I went to med school, I get my loans to pay for med school. Then I get a little for ramen and a little for a room in a co-op, right? I get a little living money too. So you can imagine if you pay, I went to paramedic school, I did it in 3 months, right? From an EMT. And it was because it was my full-time job to go to paramedic school. Right? My rent was paid, my food was paid, my gas was paid, and so we did 5 8-hour days, right, during the week, and then we did clinics and internships on the weekend. And after 3 months, we sat for the National Registry, right? So you could do it that quickly if you had complete financial support. So you can imagine a bill like this would provide that. It would either be, we'll give you a loan and then we'll forgive the loan if you graduate, right? Or some other version of that, or just a straight up scholarship. As long as you're making your grades, we're paying. And so, with the workforce shortages we have, this is, what the nurses are doing, right? And so again, I think it's a 4 for us because you could just take nurse out of the legislation and insert paramedic, and you basically had the same bill if anybody wanted to. All right. Senate Bill 60, the associate's degree. Here we are again. So the exact language prohibits the Oregon Health Authority from requiring an associate's degree or higher for eligibility license as a EMS provider. So there you go. That's the entire bill. It's like one line. Can't require an associate's degree to be a paramedic. As an employee of the executive branch of government, I have no opinion on this one way or another. I would just point out, though, that there may be a couple of semi-independent state agencies that would take issue with the legislature telling them what the required degree requirements for their licensees are. And I'm just thinking, and there's a cartoon playing in my head, and there's my cousin Earl, and he's like, damn, I always want to be a doctor, but I got no goddamn doctorate degree. I'm gonna just go to my legislature and get them to pass a law that says Oregon Medical Board can't require doctors to have doctorate degrees. But, I mean, it's literally the same thing, or nurses to have nursing degrees or anything else. So there's a bill out there that says, yeah, the EMS board can't require paramedics to have associate's degrees, and it's a slippery slope from there. But anyway, it's out there. Here's something more interesting. House Bill 2408, the nursing compact. Does anybody know what interstate compact is? What's that? Trade? It does have to do with trade. It has to do with interstate commerce, has to do with travel. Let me ask you something. Who has a driver's license? Is an Oregon driver's license? Can you drive in Washington with it? Can you drive in Idaho with it? Can you drive in Colorado with it? You can drive in all 50 states with your driver's license. That's because there's an interstate compact between all 50 states that says basically we have pretty much the same standards for our driver's licenses you have. And if you get a ticket in Colorado, we're going to take action on that here in Oregon on your license, as I found out when I didn't pay my Washington ticket and tried to renew my license. Right? They're like, yeah, you can't renew your license. You got to go pay Washington $400 before you can. So that's the interstate compact for driver's licenses. There's interstate compacts for everything. Betting on dog races, like everything. And it all has to do with interstate commerce, right? So this is the nursing compact. If you get a nursing license in any of those blue states, you can use that nursing license in any of those other blue states, right? This has been around forever.
So is Oregon kind of not on board with that because mostly our standards are a little higher than other states?
That is beautiful explanation. I love that. The entire West Coast is not on board for any medical licensing compact there is. And sure, because we're better than everybody else. Maybe. But this has been reintroduced for like the 10th time. No, and I'll let you figure this out, like no coast on the left coast participates in any medical interstate compact, nursing or otherwise. And maybe it's because we're better than everybody else.
Training and licensing standards higher than most states.
Yeah. Like it-
Does it come down to where Red State approves it?
Well, I mean, I'm going to let you make the association right here, but yeah, all these legislatures are dominated by a supermajority of Democrats, and all the executive branch are dominated by a supermajority of Democrats, which isn't the total answer, but it's about like why are we dominated by Democrats? Like who funds that?
West Coast states are also the highest nursing paid states.
Yes, they are, which is another part of the answer. Anyway, it's a 4 for us because of this, right? I don't know if you guys know about this. It's been around for 2015. An act's recognition of the EMS personal licensure interstate compact, right? So we have the same thing as EMTs and paramedics. We have the same thing the nurses do. As you can see, it's not as extensive. it's only 22 states, so a little over half, but every year a couple more states join, right? Eventually, most of the states, but as you can see, for kind of the same reasons, because we're better than everybody else, I'm thinking, is that the West Coast doesn't participate in any of these compacts. This compact has been introduced again for the third time in the Oregon legislature. So it's up there right now if you want to talk to anybody about it. Same thing, if you have a license in any of these states, you can practice in any of the other states. And California will never be on board because they have LEMSAs, they have this weird thing where EMTs are licensed at the state level, but paramedics are licensed at the local level with local scopes of practice and local medical directors. And so for them to have a state, there is no such thing as a state paramedic license in California from a practical standpoint. But Washington definitely could. And Washington's always said for the EMS compact, they're like, well, there's no point in us doing it if Oregon's not doing it. So it's sort of a chicken and the egg. Like when one state gets on board, the other state probably will. Montana is like really weird in that they, yeah, their EMS bureau is like staff, a bunch of lawyers, and they do weird stuff. But anyway, there's an EMS compact. Oregon wasn't the first state. It might be the last state, probably not. California is probably going to be the last state. But it's up for its third time in the Oregon legislature. And, you know, if you're somebody who lives on the Washington and Idaho or California border and you have to maintain 2 licenses, that would no longer be the case if the EMS compact passes.
Do you have any contact info on who we can email about this? The EMS compact?
So Ray Mollers runs the national EMS compact. And as for the legislators that introduced it, like what kind of contact info do you want?
Just who do we need to talk to? Be like, hey, please.
Well, your local legislator, your senator or your representative is going to be the one that's going to either vote yes or no. And I mean, that's the way the democracy works. Like they have to respond to you. If you contact my legislator, they're going to be like, you're not in my district. If you contact me, I'm going to be like, I'm part of the executive branch. I can't have an opinion on this. So you have to contact your local legislator, your senator, your representative and say, hey, this is a good thing. If you want information on the compact, they have a website and the guy that runs it is a good friend of mine. He has COVID right now, so he's not taking phone calls. But yeah, I can provide you with information about the compact. Or who you can also just Google who's my. Okay, I think we're almost there. House Bill 3126. This is an interesting one. So it established emergency behavioral health care services for children within the OHA to promote the timely delivery of behavioral health services with children who present in emergency departments with behavioral health crisis. So this is an interesting bill. It basically disassembles parts of the Oregon trauma system and it puts in pediatric behavioral health into it. So this would put a psychiatrist on the State Trauma Advisory Board, which again, I would just love to be sitting in the back with a popcorn where this happens, right? You get a bunch of trauma surgeons and paramedics and trauma nurses, and there's some guy at the end of the table with a pipe going, oh yeah, tell me about your mother, yeah. Yeah, I don't know. I don't know. I don't know what somebody was thinking here. Right, so this would put a psychiatrist on the stab. It would require hospitals to be designated as pediatric psychiatric receiving facilities. So I don't know how you're going to do that because, I mean, trauma is like, hospitals get designated as trauma centers because they want to, like, because trauma is money, right? Trauma patients, you make money off of trauma patients, right? So they volunteer to get designated as trauma centers. Behavioral health loses money, so I don't know how you're going to get them to do this. It would require regional plans and universal point of entry protocols, which Who knows what a universal point of entry protocol is? You do. I guarantee you know what it is. You just have never heard that word, or maybe haven't heard it. Here's the universal point of entry protocol. All right, you guys know this, right? CDC field triage guidelines for trauma. So a universal point of entry protocol says that if you're a patient and you meet these criteria, you're into the system, and you are into a system, right? So our trauma system is a system. We have pre-hospital trauma criteria. You get to the emergency department, there's activation criteria in the emergency department. There's all sorts of metrics and standards you have throughout the hospital, all the way to rehab. There's a database, there's quality assurance. It's an entire system. So it's a good idea. They're like, why don't we do this with pediatric, like regionalized time-sensitive emergencies, stroke, STEMI, cardiac arrest, trauma, right? Why don't we do this behavioral health? And I'm like, yeah, it's a great model, but you can't just put psychiatrist into the word psychiatrist into the trauma statute and get a behavioral health system out of it. But that's what this bill does. Yeah, so I don't know, it may affect us, it may not, whether it passes or not. You guys, maybe if you're on the ATAB or if you're on your hospital's trauma committee, you may have a psychiatrist sitting in there with you, asking you about your mother. I don't know. This is democracy is messy. All right, so speaking of behavioral health, so that was our legislative update. As of like 2 days ago, I haven't checked since then. Those are the bills that are mainly going to affect EMS that are here. Another big thing that's coming, if it hasn't hit you already, and it depends where you live, is everything that's happening around behavioral health. So emergency behavioral health care, some of the inherent problems, some of the solutions that we're going to lump under the heading of 988. So 988 is more than one thing. 988 is a number, but it's also, a lot of people just throw all emergency behavioral health care under the title of 988. So I'm not a behavioral health expert myself, but I do work in public health. I work in regionalized systems of care, trauma, stroke, STEMI, etc. And like I said, you can just throw behavioral health in there and use the same structure to do behavioral health, which is what a lot of people think we should do. Nobody's got my reference here. No, I'm not. Thank you. All right, I appreciate it. So the ED divert holding behavioral health. Who? Yeah, you guys aren't nurses. Any nurses here? Any charge nurses? So you use HOSCAP?
Yes.
Yeah. So you recognize this. So we have a system that shows the status of all the hospitals in the state, and every charge nurse and every ED has this thing up all the time. It's one of their screens. And when the whole system is red, you can look at the right column and see why everybody is red, and so it's this. ED's on divert holding behavioral health, right? Got behavioral health. So that was that. Anyway, so let's start with the case. So 40-ish male, law enforcement called for bizarre and violent behavior. I know you guys have never seen this before. Placed on a police hold. EMS on scene, law enforcement physically restraining, EMS transports the ED. Patient gets the ED, he's got no chief complaint, just wants to go. It's like, what you guys are doing with me here? I was just, running around through the street shouting. He's alert and oriented ×3, but rapid pressured speech, tangential thoughts, making bizarre remarks. He remarks about the CIA following him around. You think the CIA remarks may be paranoid delusions. I don't know why you think that. To me, it's like, if I'm walking through the ED and I hear the words CIA, it's like an immediate trigger. I'm like, oh shit, here we go again. Like, it's never Fish and Wildlife, right? It's like Fish and Wildlife found out about that elk last year. I'm like, no, it's always the freaking CIA, which I don't understand. The CIA is like foreign espionage. It's like, no, dude, it's the NSA that's spying. Those are the guys that are actually spying on you, not the CIA. So, the words, whenever I hear CIA, is rapidly followed by the freaking police coming through the emergency department. I'm like, okay, here we are, off to the races. So it's unclear if he's a harm to himself or others, but he's a busy emergency department, police holds. You may not know, but they expire the minute I see the patient, the police hold is gone. So I have to immediately decide whether to put them on a behavioral health hold. BT dubs, there is no medical hold in Oregon. That's not an actual thing. If it's not psych, danger to self or others, can't legally hold a patient. I know people do it all the time. It's illegal. So put them on a behavioral health hold until you can, figure out what the heck is going on. Okay. So this situation seems normal to me, but because I go through it every day, but a lot of people in the mental health community perceive this a lot of problems with the model of behavioral health care. And advocates have identified 4 problems, and that's 4 solutions. So they're problems with our emergency behavioral health care: who we call, who we send, where do they go, and how to prevent what I'm going to call readmission, but you can call recycling, how to break the cycle of needing behavioral health care chronically to needing emergency behavioral health care all the time, right? How do you stop them from re-entering the system in an emergent way? All right, so let's start with the first one, who to call. So if you're having a behavioral health crisis right now, there's a suicide prevention line, right? There's a national suicide prevention line that it's not just for suicide, it's for any mental health. They'll plug you into resources, behavioral health resources, or they'll direct you to 911, right? If they think there's a threat to life safety. Who else can you call? Well, I have Kaiser, I love my Kaiser. It's not great if you need like specialty, orthopedic trauma care and rehab, but for general stuff, it's pretty good. You can call the nurse advice line. Anybody ever called a nurse advice line here? Come on, somebody here has had a prostate problem or something, or a sprained toe. Nobody's ever called a nurse advice. Anybody ever called their doctor's office? Oh yeah, there's that. You ever called your dentist's office for an appointment, your doctor? What if you call any medical office ever, what's the first thing that happens?
Put on hold.
Before you get put on hold. Before you get put on hold. If you're having a medical emergency, call 911. We're going to get to you. We're going to get you. It was the title of the talk, 988. Yeah, so you can call the National Suicide Hotline. You can call whatever your healthcare provider's nurse advice line is. It'll immediately, before you talk to anybody, before you get put on hold, it'll tell you to call 911. Or you can call 911 because that's what, right, we do. If you have we've told for decades, we tell everybody, see something, say something, right, call 911 no matter what. So that's what we do. There's a few problems with this. The general public doesn't have, they can't self-triage. They don't know who to call. They don't know when it's appropriate to call any of these numbers, right? Because they're not medical professionals. And so they tend to end up calling 911. And so we've got 36 counties with about 42 primary PSAPs. Everybody good with PSAP? That's your public safety answering point. That's your 911 center, right? That's the official name for it. And I don't know, 42 primary PSAPs. I don't know how many secondary PSAPs. Could be over 100. And the PSAPs are using at least 3 different medical triage systems, right? Some people use priority dispatch, medical priority dispatch. Some people use APCO. Some people use the PPSST card set. And some people just wing it, right? They come up with their own stuff or some hybrid. So the public doesn't know how to call. And when you call, you're going to get a completely different triage system. And that triage system is based on what assets are available, right, in the location you're at, which goes to our next thing, who to send, right? So you call 911, but, based on your location, you could have a 5-tier response system, or you could just get the same asset every time. And that asset is a volunteer EMT in an ambulance. Like, it's simple. You don't need priority dispatch because there's only one asset, and that's what's going. It's either a sheriff, deputy, or basic EMT, or both. So, but there are other, you know, if you live in a major metropolitan area, they may have this multi-tiered response system where you get police, you get fire, you get mental health, you get a hazmat unit, you can get who knows, right? They have multiple options to pick from. So who to call, who to send. So about 90% of all PSAP calls are law enforcement calls, and about 90% of all behavioral health calls, the initial dispatch is law enforcement. If anybody cares to whip out their Google machine and Google the phrase behavioral health dies in custody, this is what you're going to get, right? So I Googled that exact phrase. I got 26,200,000 hits in 0.26 seconds. So this is the perceived problem about who to call and who to send, right? Call 911, you're going to get a law enforcement response, and then you get all this, right? So people are talking about this. People are getting sued over this. People are getting indicted and sent to jail over this. Police chiefs are either losing their jobs or making their careers, depending on what side of the fence they land on. As we mentioned earlier, right, it's not just law enforcement anymore. We're getting sucked into this. 2 paramedics are indicted by the grand jury, you know, over this. So it's an issue and it's landed in our lap now, right? We're in the firing line. So who to call, who to send, where to go. I probably shouldn't go to jail, right? Unless you're like committing a crime. And even if you're committing a crime and you don't know you're committing a crime, probably jail's not the best part. By default, we go to the emergency department for lack of anywhere else to go, right? Because it's the only healthcare facility that's open 24 hours a day and will take anybody. And even if there was somewhere else to go, for most of us, there is nowhere else to go. This is Portland. You actually do have some choices. You have the emergency department. They'll definitely take you. You have Hooper Detox. They may take you. You have Unity Independent Psych Hospital. They may take you. Emergency department has to take you. These other places don't have to, right? And then there's, you know, there's how you're licensed and paid, right? So you don't get paid to take people to Hooper. The insurance company's not going to pay for that, right? They're not a licensed healthcare facility. Unity is, but because it's licensed as a satellite of the legacy emergency department. So for billing purposes, it looks like you brought somebody to the emergency department, but that's not the model everywhere. If you have something that's not licensed as a hospital that'll take your patients, maybe you can take them there. You're not going to get paid to take them there. So I don't know how much the taxpayer is going to suck up that bill for you if you're a public agency. If you're a private agency, you'll never go there, right? You got to get paid to keep the lights on. So, you know, for now, it's the emergency department for most places. You got nowhere else to go. And then there's, you know, so who to call, who to send, where to take them. And then how are you going to keep them from chronically re-entering the system? What is this right here? It's groundhog. All right, bonus points. What's the difference between a groundhog and a woodchuck? There's no difference at all. It's just groundhog. How much wood could a groundhog chuck at a groundhog chicken? It just doesn't work. Woodchuck and a groundhog are the same thing. So back to where we started. 40-year-old male brought in by police hold, behavioral health hold. You get some more information from the police. He was running around the street, shouting, throwing things at people. Enough information to determine that he's a harm to himself or others. So you place him on behavioral health hold, give him some olanzapine ODT. What does ODT stand for? Under time. I'm glad you said that. So it stands for oral dissolving tablet. But we had some cherry nurses come down from MedSurg because we had a nursing shortage and we were being mentored by some of our salty old, I call them salty old nurses, but they're not really old. Like just being in the emergency department, like, yeah, it makes you hard. Right? So they're probably only like 25, but they're like salty as shit. They look like cream. Right? 'Cause that's what ED nurses are like. And this young nurse, she's like, what does ODT stand for? And the charge nurse walks by and she's like, on tongue. And to this day, those young nurses still think that ODT stands for on the tongue. Anyway, so he gets olanzapine on the tongue, seen by the psych social worker. He's still there at the end of the shift. You come back the next shift, he's still there because ED divert, holding behavioral health. There's no psych beds. They just live in the ED. But by, he's de-effervesced from the meth that he was doing, and the olanzapine ODT has kicked in, and now he's not holdable anymore. He's rational. He's like, I want a cigarette. I'm out of here. And so you have to discharge him. And so how are you going to prevent this guy from Groundhog Day? What's going to keep him from coming back the next day? And this is literally exactly what you get from. So we don't have a social worker 24 hours a day. It's 9 to 5, Monday through Friday. But even if we do have a social worker, here's what you get. You're going to get not even a pamphlet, a photocopy of a pamphlet. And I don't know if you guys can even read this. It's got a phone number. So if you want substance abuse treatment, there's a phone number. You call this number. Right? And if you're homeless, you get another photocopy of a pamphlet. And it says, here's, if you don't have a place to stay, here's a place, call this number, here's a place to stay. And then you get another piece of paper, which is like just a cutout photocopy that says, if you want mental health, call this number, and within 48 hours, we'll get back to you. You won't get mental health treatment in 48 hours. We'll get back to you in 48 hours.
Yeah.
And then you get a bonus, right? And so the guy takes his bus pass and he throws everything else on the floor as he storms out of the emergency department. And next day, same thing. Police hold, intoxicated on meth, homeless, nothing, right? And so this is that last piece of that picture. Like, how do we stop this from always happening? And so the legislature passed a bill and they said, hey, Oregon Health Authority, you guys, with your vaccinations and your hand washing, and what are the 3 tenets of public health? I just gave you 2 of them. Wash your hands, get vaccinated. What's the last one? Don't poop in your drinking water. That's it. Like, that's 90% of public health right there. Wash hands, get vaccinated, don't poop in your drinking water. They're like, you guys solve this problem. And sort of same thing, we bring in some, the experts, and they're like, yeah, you guys got a problem. Who to call, who to send, where to bring them, and then how to keep them from coming back in the system. Wraparound discharge services. That's respite services, behavioral health, urgent cares, counseling, housing, food, addiction services, etc. And so they imagine a model, because you guys are so good at what you do, everybody else wants a system that does what you do. Right? So who to call? 911. Who was it that said it? Call 988. You got a new national number. So if you call the National Suicide Hotline, it goes to 988. Who to send? EMTs and law enforcement, local crisis teams. Right? Where to go? Emergency department, crisis stabilization centers. And then what to do afterwards? We get all this fancy medical care and rehab. We have these behavioral health services. So the idea is that we're going to create a parallel system to the emergency medical system for emergency behavioral health care. So where are we at with that? All right. So I've already run over, so I'm going to go real quick, but nobody's coming in barking at me, so I'm going to just keep going. So dispatch, you can call 911, you can call 988. Oh, here they come. I talk too much. I could talk for another hour, but so now we have 2 988 dispatch centers in the state of Oregon. You can call 988. If they perceive life safety threat, they're going to shunt you over to 911. If you call 911, your PSAP may or may not be doing this, but they could, and it's adjudicated as a low-level call, like you just need to talk to somebody. They could send in a 988. And then there's grants to the counties to have these multiple levels of response. You're just a criminal, You get law enforcement, you go to jail, you're just a medical, you're hypoglycemia, it's not behavioral health at all, you go to the hospital, or you're some mix. Like you're suicidal, we need some law enforcement, we're gonna send a behavioral health team, or you're just behavioral health. And then there's the last part where, you know, you go to jail, you go to the emergency department, you go directly to a psych center, you go to some like respite center. So that's the idea here. So the legislature was really ambitious in their timing. So what have we done? We've got the 911 centers going. We've handing out grants and rules to the counties to get the mobile teams. But the receiving facilities, we haven't started on that yet. Lots of people commit, so 70 people a month commit suicide in Oregon. That has not changed for years. It doesn't change for a month. It's a problem. These guys, 988 versus 911. Let me just tell you a couple of differences. Okay, you call 911, you guys know what 911 does. Call 988, they plug you into behavioral health or they shunt you over to 911, one of the two. 988 does not do a lot of things 911 does. They have no CADs. They can't electronically hand off calls to either the mobile response teams or to 911. They can't geolocate you like 911 does, right? And you can't make emergency calls to 988 on your phone like you can with 911.
So we had somebody call a suicide prevention hotline.
They get shunted to 988 now.
And they were actually GPS, and we located them off of the GPS signal.
Well, you got dispatched,
Yes.
right? So one of the big, I'm not going to call it flaws of the system, but what you have to understand is the 988 advocate said that 988 was going to take 20% of the call volume away from 911. But if you need police, fire, or EMS on that call, what does 988 do? They shunt it back to 911, which is why you had the location.
So that's how they got the location.
That's how you got the location. No, it was from the 911.
Oh, okay. I'm like, well, then how did that get GPS?
All right, so we could talk about this a long time. I have run over. Thank you all. I'll be out outside if you have any questions about any of this. Thanks for your time. Thanks for being here.
Thank you.